Good morning. Sorry guys, my webcam is not working at the moment, and also my printer wasn't working either. And if anybody wants a slightly used printer, there's one out on Laguna Drive in Johnston. Ophthalmic Surgery, Chapter 16. I'm going to do my best to voice over this presentation as best I can. This chapter is about the eye, sensory organ of sight, protected by bony structures. As we know, it converts light energy and sends it to the brain. The orbit of the eye has 7 bones. We went over some of this anatomy in class. The extrinsic muscles function in a fashion to move the eye in various directions, and we talked a little bit about those muscles. There are rectus muscles at 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock if you look the eye straight on. The superior rectus muscle makes the eye move up and medially. The inferior rectus muscle at the 6 o'clock position moves the eye down and medially. The lateral and medial rectus muscles lie. The lateral rectus muscles are on the outside of your eye, towards the outside of your head, and the medial rectus muscles are closest to your nose. They're on that side of the eye. There are also oblique muscles, and those muscles are, the way to remember those is they are kind of the counteract of the rectus muscles. So the superior oblique muscle would move the eye down and laterally, and the inferior oblique muscle would move the eye up and laterally. Lacrimal system secretes tears and keeps the conjunctiva moist. The anterior chamber, located between the cornea and the iris, is where the aqueous fluid flows through the space to provide nourishment to the tissues of the eye and maintain the shape of the eye. The posterior cavity is larger, and it contains a similar gelatinous substance called vitreous humor. Helps keep the pressure in the eye. The Schlemm canal is the outflow of the aqueous humor and the communication between the anterior and posterior chambers. There's the 7 bones of the orbit. We kind of talked about those in our class. And a better look at the muscles. We also looked at those in class. And there are what they do on a slide for you, as I just mentioned. The lacrimal gland. And important to know, the lacrimal system drains into the nasal cavity. It's located in the upper eyelid at the outer angle of the orbit. And fluid is carried away by the canals. There's a superior and an inferior canal along the duct into the cavity of the nose. Picture of the globe, not a very good picture. As I said, conjunctiva is that mucous membrane that covers the eye. The sclera is a firm fibrous membrane, and that helps keep the shape of the eye, keeps it round. The cornea is the transparent exterior part of the eye. It is circular in shape. It is also avascular, and it refracts light rays, and it's made up of 4 layers: epithelial cells, substantia propria, elastic lamina, and endothelial cells. The sclera and cornea make up the external tunic of the eye. There are 3 tunics of the eye. The choroid, the ciliary body, and the iris make up the middle tunic of the eye, which is also the vascular tunic. The iris, as we know, is a thin circular membrane, and it's suspended in aqueous humor between the cornea and the lens. It also is pigmented and has the color of the eye. The retina makes up the inner tunic and is the membrane of which all our images are recorded and sent to the brain. The rods make up the part that sees shades of gray and also general shapes. The cones provide color and sharp images, and there's a small depression called the central fovea that contains only cones. That is our highest visual acuity in our eye, in that little depression called the central fovea. Crystalline lens, as we know, is transparent and biconvex in structure. Situated behind the pupil and anterior to the vitreous body. So in front of the vitreous body. Glaucoma is a condition. There are several different types, but the main thing about glaucoma is it's increased pressure in the eye caused by the inability of aqueous humor to go through the canal. The procedure that we do for that is an iridectomy, or if you're south of 80, an iridectomy. Cataracts we watched a video of in class, and that is a lens that has become opaque, mostly due to age, sometimes trauma. It gets cloudy. We'll talk more about that later. The retinal detachments are small flashes of light where people will see, they see floaters, things like that. That's when a tear in that retina has caused part of that wall to become detached, and we lose vision at that point. We'll talk more about the procedures to fix that in a little bit. A chalazion or chalazion is a cystic inflammation trapped inside an oil gland in the eyelid, basically. Pterygium is a wedge-shaped fibrovascular growth of the conjunctiva that extends into the cornea. They're benign lesions usually found on the sides. Dacrocystitis, inflammation of the lacrimal sac, just caused by obstruction of it, makes it get inflamed and infected. Strabismus is where we have a misalignment or a condition where the eyes deviate from their normal track. Esotropia is called crossed eyes, where your eyes are turning inward, and exotropia is wall eyes, where they turn outward. Some medications. Mydriatics cause pupil dilation by paralyzing the iris. Some drugs there, atropine sulfate and phenylephrine, can dilate the eye. We use this to examine the retina and prepare the eye for ophthalmoscopy. Cycloplegic is used to paralyze the ciliary muscle. A couple drugs there, tropicamide and cyclopentolate. Viscoelastic is used to expand the chamber. We saw that in our cataract surgery video. You can kind of blow that up a little and irrigate it out. It can also be used as a vitreous substitute. Miotics are constricting agents. Acetylcholine, pilocarpine, carbachol, they constrict the pupil. Hyperosmotics are used preoperatively to shrink the vitreous body. That takes the pressure off that vitreous area. Anti-inflammatory agents, there are steroidal and non-steroidal. Non-steroidals are used for post-op inflammation. Prednisolone, dexamethasone or decadron. Betamethasone is celestone. Ophthalmic ointments are used also for infections, but sometimes used post-operatively also. Aminoglycosides, gentamicin, neomycin. Lubricants, lacquer lube, Duratears, keep the eye lubricated, prevent drying of the cornea. Some local anesthetics that are used, tetracaine, proparacaine. We use these for retrobulbar blocks, and we talked about those in class a little bit. They can have additives of white-ace or epinephrine to prolong the duration of the block. Balanced salt solution is used a lot as an irrigating solution. The surgical technologist must have knowledge of how to run the microscope and also be comfortable looking through the microscope so you can irrigate, cut sutures, things like that, just to be able to anticipate the surgeon. You also have to be familiar with the machines that they use, the phaco machine and the laser machines, and some of the other equipment that we use for ophthalmic surgery. One thing that's important is you have to be able to hand things to the surgeon without them having to look up, so they don't lose their field of view from the microscope. As I said, you need to get comfortable looking through the microscope. Often these eye cases, you don't get to scrub them that much as a student because you need to be familiar in order to scrub these well. Some forceps, Colibri forceps hold the edges of the cornea. and the sclera when we incise them. And there's some non-tooth forceps. We looked at a lot of these in class. Some are really fine. Sometimes they'll call them jeweler's forceps. A Bishop Harmon is for the iris. A Demar Calazion forceps looks kind of like a Judd D. Martel. It's kind of like a clamp, and it isolates that Calazion so you can operate on it. Needle holders we talked about in class also. There are Castroviejos that lock and some that don't. They don't have a ratchet if they don't lock. So you have to hold those very carefully so you don't drop the needle when you're passing it to the surgeon. Slit knives and some of these other knives that are listed on the slide, used for incisions, sometimes for scraping clot. They have a lot of different uses, but a lot of them you're making a small slit on the side of the cornea so you can get the phaco tip inside there. Hooks and retractors, used just for what they are stated as on the slide, just used as retractors. Demar lids look like vein retractors. Eye speculums look like an unfolded paper clip, and they're usually made of spring steel and just kind of hold the eye open. A lot of different scissors as we saw in class also. Some are spring action, meaning when you squeeze them they come together, and when you let go they open up and pop out. Bowman probe is that real fine probe that looks like it kind of has a butterfly in the middle. That's for probing the lacrimal duct and checking its patency and for obstruction. Some other common equipment that you may see in an eye room. Special equipment, a phacoemulsifier is an ultrasonic energy, and it kind of chops up that hard lens material, and then you can suck it right out. They'll expand it a little bit with some viscoelastic inside there to create a little more workspace. Take the phacoemulsifier and chop up the lens and suck it back out. Sometimes they'll take the cornea off at the same time. Sometimes they just take the lens out and put a new lens in. Fold it in half on a forceps and slide it in there. Common lasers are argon or YAG lasers for photocoagulation, and sometimes CO2 lasers also. Cryotherapy is used. We use extreme cold temperature to seal some of the tears on the retina. It works a lot like a diathermy, which is kind of like a cautery, and especially in diabetic retinopathy, they build up a lot of, their vessels get kind of big there and sort of get crowded, and we have to do something about those vessels to shrink them or burn them so that they don't throw clots into the eye. Some more routine supplies. We looked at some of this stuff in lab. The Wexel sponges can also be called Wex spears. They look like a little spear with an arrow point at the end. Sterile cotton swabs usually have a little shorter stick than you see in other specialties. Suture material is often the surgeon's preference, but they can be very fine sutures, and we're going to load them on those micro needle holders or Castroviejos. We talked about BSS, prevents the cornea from drying out. The needles you're going to use are going to be small. 27, 30 gauge are very small. The needles we use for sutures in eyes a lot are a spatula needle. There are many approaches for eye surgical procedures, and one thing that's pretty common is you don't do a lot of talking and moving around. Non-powdered gloves when we're doing these cases. Lint off of our instruments. You can cover your mail stand with an X-ray cassette drape. It's just a clear plastic drape that goes right over your mail stand. That keeps a lot of the dust and lint off of the instruments and helps keep them clean. And a microscope. Eye surgery was the first specialty to use a microscope, as I said in class. Of course, we don't want to pool prep solution near the eye. You'll irrigate with a bulb syringe filled with BSS, or, like I said, there are sometimes little Aldredi or Titus needle type things that you can screw onto the end of that little BSS tube that comes sterilely, and you can irrigate right through that from that tube by squeezing it. We sometimes trim the eyelashes, and there's usually an aperture drape that just drops over the head and leaves the eyes exposed, sort of covers the rest. You may also use a U-drape just like we had in lab. Some of the procedures, the repair of the Calazion, it's kind of an I and D of a cyst on the eye basically, and you're just opening it up and draining it, cleaning it out. We sometimes repair the muscles. Iridectomy I talked about a little bit, and that's usually done for glaucoma, and we take a full thickness chunk of that iris out so that the aqueous humor can then flow through the chambers. Strabismus correction, we're going to resect or recess the muscle to correct the eyeball movement so that it tracks properly. Scleral buccal, we're going to put a little piece of graft in the sclera and kind of tent it together to pull the retina back up against the sclera, and that will help improve the shape of the eye so that that retina will lay back down on the back wall and improve our vision. Dacrocystorhinostomy, we're going to clear a path for the lacrimal ducts. Enucleation, we're taking an eye out. Keratoplasty is a corneal transplant. Cataract extraction can be done either inside the capsule or outside the capsule. Sometimes they'll make that little slit just like we saw in class and phacoemulsify it and pull it out, fold a new lens in half and slide it in with a forceps, just like we saw in the video. Vitrectomy is mainly done to remove clots. Like I said, in diabetic retinopathy, you're getting a bunch of vessels that are becoming dilated around the eye, and eventually they hemorrhage or bleed and put clots in that vitreous humor, which impedes the vision. So oftentimes they will go in, remove the clots, take the vitreous out, and laser repair the retinal tears. Sometimes they'll use CO2, sometimes they'll use diathermy, but they're going to try to shrink or obliterate those big vessels that are causing bleeding and loss of vision on the back of the eye. It also can tack the retina back onto the sclera, and wherever you burn it or endophotocoagulate it, it will stop the tear from going any bigger and form an adhesion around that site, which will keep it from tearing further also. In the short term, we'll refill that area with some gas. Some of the gases are on there. For a long-term, more stable solution, they can inject silicone oil in there. If they put gas in, you're going to have to sit in an upright position to make sure that gas bubble doesn't float around to the wrong direction, because we want to keep pressure on the retina so that it attaches and heals to the sclera, kind of going back into its position. Some of the things we went over are right up there. A lot of different special equipment. Your clinical site is going to have different equipment varying on what types of surgery the eye surgeons there like to do. And we went over some of the pre-op, intra-op, and post-op care and some of the medications involved with that. Thank you.